Hi, we keep going. So this is just something to think about as we talk about medications and children. The pen is mightier than the sword. So this probably needs a little bit updating in terms of the e-prescribing world, but the message is the same. You're more likely to cause harm to a paediatric patient through medication, through prescribing medication than any other medical action. So children, they're particularly prone to medication-related harm, and up to 15% of inpatient prescriptions have errors on them. And children, they're 3 times more likely to than adults to be harmed by medication. So just always think twice before you prescribe anything for a child, and is it actually necessary? Is it the best course of action? They are a higher risk group. It's particularly because it's a weight-based drug calculations for each individual patient, and the patient's weight can vary so greatly from 500 grams to 100 plus kg teenagers. So the potential for error is huge. So this just to show you some examples of things that unfortunately do go wrong. This was a 4-month-old baby who died from an overdose after a mother was given the wrong prescription. So unfortunately, the receptionist at the doctor's surgery made out the script at the dose of 5 ml twice a day instead of 0.5 ml. It was signed off then by the doctor, who didn't pick up the error, and then it was dispensed by the pharmacist, even though the technician had queried it over the phone, but he had thought it was with the doctor, but it was actually with the receptionist. So just errors can happen from at any point in the medication process, but even at the very, very start, just when the dosage is being prescribed. This is another example of an error that can occur. Child was prescribed an anticonvulsant, usually in a 5 milligram per 5 ml solution. However, the dose was prescribed and the label for the 5 milligram per 5 ml solution was applied to a 25 milligram per 5 ml bottle of medication. So this this error went unnoticed, and the child received an increased dose for several weeks before being admitted to hospital with breathing difficulties. So then on admission to hospital, then they used the patient's own medication for further doses. And again, queries about the discrepancy between the strength of the bottle and the label didn't result for several days. So just the point I want to illustrate here is the labelling of medication is definitely an area where errors can occur as well, and can result in repeated medication errors. And this was compounded in this case because they used the patient's own medication during the hospital admission as well. So children are not small adults. They may look like it sometimes, they dress up, they try their best, but in terms of medications, drug dosages in children, they're often determined by pharmacokinetic and pharmacodynamic factors. And children, they change frequently. Their age changes, their weight changes, their body surface area changes, and as a result, drug calculations all depend on these factors. So there are several steps in calculating dosages for children, so they're predisposed to an increased chance of error. It's not as easy to pick up. We don't have standard dosage regimes in children. It's a lot easier in adults. We have paracetamol, 1 gram QDS is correct for the majority of the population. Children is completely different. We don't have as many licensed medications for children also, so we have to use unlicensed products and off-label medicines as well. So again, it limits the clinician's choice and increases the risk of error with children. Most of these changes in terms of pharmacodynamics and pharmacokinetics in children, their metabolism of the drugs, their excretion, most of them take place by around the age of 2. So it's these younger children that we really have to be very careful in terms of medication. Another visual, just to sometimes a picture paints 1,000 words. So these are 2 little babies, 2 newborns, believe it or not. So the one on the right looks like it's definitely grown a little bit more before it was delivered. So even from the very, very start, babies are different weights, and there's no one size fits all. So just bear that in mind. As a child grows up, it's the exact same. Every single drug dose is individualized for the patient, and we have to be very, very careful at each step in the drug calculations. So why are young children more vulnerable to medication errors? There's many reasons. These are some of the more common reasons that we have are to do with age and weight calculations. so milligrams per kg or milligrams per meter squared. And age and weight changes again over time constantly, so it's something we just have to keep monitoring and keep reviewing doses, not just assuming because a dose was prescribed a couple of years ago that it's still the correct dose for this child. Another reason, inadequate or misinterpretation of information. Particularly this can occur at the points of transitions of care. So the World Health Organization, they focused in on a few different areas for medication safety, and one of their key areas was the transition of care of patients. So this is at the point of admission to hospital, the point of discharge, and also transfer between one hospital and another. So if a child is coming from the CHI hospitals, Temple Street or Crumlin, and they're coming back to Letterkenny Hospital where I work, you just have to be really, really careful in terms of the communication of doses, making sure that the information is said correctly. So definitely something to watch out for. Another area, we don't have as many suitable licensed dosage forms for children, so it's harder to select. Whenever you talk about unlicensed medicines, the range of medications that you can order is huge, so we just have to ensure that the correct dosage is selected at each point. Also, conversion of units and decimal points and abbreviations. This seems so simple, but it's a huge area of concern in paediatrics as well, and the consequences can be quite severe. So I'll talk a little bit about that very soon. So a wise doctor once wrote, good for fair play, hats off to anyone who can read this. The point I want to illustrate here is we accept lax prescribing too often and illegible handwriting. It's a huge cause for concern in terms of communication. So just something to bear in mind, we shouldn't accept it, it shouldn't happen in the first place, and just take that extra bit of time, particularly with paediatrics. They're a high risk group, so please be more cognizant of it. So hopefully I'll give you a few tips just on how to improve prescribing in paediatrics. Some of these slides come from the Clinivi app. I don't know if many of you know about it. It's the formulary used in the CHI hospitals in Crumlin and Temple Street. It's a fantastic resource. So it's a free app to download. If you search for Clinivi, it'll come up, and if you follow then the CHI library, and there's also clinical guidelines as well, which might be useful for some things in community also. So they have a nice little section on that. I'll speak a bit more about Clinivi later on, but they have a nice section on that, on abbreviation, some general information and medical safety information for doctors working in paediatrics. So abbreviations, it's really basics. The ones in green are good: grams, milligrams, mg for milligrams. Whole words, please spell out the whole word. Micrograms, it should be spelled out. We should not use abbreviation mcg or the little squiggly ug. Ml and nanograms, they're all fine. However, please don't use, we shouldn't accept IU or U for the word units. It doesn't take a lot of extra time to write the whole word units out. Unfortunately, there has been well-documented errors where the U has been misread for a 0, which results in a 10-fold overdose. So please don't use IU or U, use the word units. The next slide is about decimal points. Again, I would hope this is not the first time that most of you have ever heard about these sort of things, but sometimes a little reminder on the basics goes a long way. So 10-fold medication errors are a significant source of risk to paediatric patients. So we should never omit a 0 before a decimal point. First of all, only use a decimal if it's required. Never write 0.5 of a gram. Instead, write 500 milligrams. It's a lot clearer, and the risk is that 0.5 grams, if that point is not written nicely or neatly, it could be mistaken for a 0, and it can just cause confusion, or it could be missed altogether and result in a much different dose. Also, never leave a trailing 0 after a decimal point. So never write 5 milligrams. There's no need for it. Just write 5 milligram. Again, the risk is that point could be misread for a 0 and could read 50 milligrams instead. So sometimes it's easier to illustrate this point with a visual, I know it's a hospital drug, it's an IV, but just to illustrate the point, you can clearly see this dose should have been gentamicin. It was gentamicin 11.6 milligrams, nice and clear, lovely written. However, this is the same dose that was intended, but it's very hard to see the decimal point here, and it could be easily misread for 116 milligrams. So please just be very careful with decimal points. It can have very serious consequences. Again, picking up a serious drug error in a child is a lot harder. So this is a visual of what it looks like in an adult. So the actual dose is on the left here in the syringe. And if you were to give a 10-fold overdose to an adult of this drug, it would look like this on the right. So 2 syringes were needed. So it's quite, you would hope it's quite obvious in an adult. However, in a premature neonate, I know you don't deal with these in community, but just to illustrate the point that they're much smaller doses in children, and sometimes it's very hard to pick up on an overdose in a child. So the actual dose is on the left in a 1 ml syringe, and the 10-fold overdose is on the right. So again, we're talking really small doses, so we just have to be very, very careful. Even the consequence is a 10-fold overdose in both scenarios, but a lot harder to pick up in a child. So again, these few slides have some of the information is from the CliniB app from the CHI hospitals on their guidance on prescribing in children. Really simple, just use black pen, capital letters, can save lives. That wise doctor who wrote the little bit of information there on a couple of slides ago, he could really have done with using some capital letters. So please don't underestimate the very basics. All elements of a prescription should be complete. We should always have the patient's name and address, I would hope, but date of birth and patient's weight, these 2 things are often missed on a paediatric prescription. We cannot verify a dose is correct without these 2 pieces of information. We shouldn't dispense it, we shouldn't be prescribing it without the weight and the date of birth. Okay, so we have a weight on a script. However, take a minute to check, is this weight appropriate for the age? Is this a recent weight? Weights should be dated. We should always kind of think, is this correct for this age? Is it an estimated weight? Possibly we've just got a variable from a parent over the phone to do a dose. We should always obtain an accurate weight as soon as possible and record it. This is really important, not just in terms of prescriptions, but in terms of writing documents, medication notes as well. Just making sure that we record it's an actual weight or an estimated weight. We have to look at the height as well. Is the weight correct for the height? Does ideal body weight need to be used instead? It's something that's not looked at that often in peds, but I think as our population, unfortunately, obesity is growing, and we just need to be very aware of it in terms of prescribing for pediatrics as well. There's a nice little article here. I don't have time to go through it all today, but some bedtime reading for anyone who's interested from the SPS, the Specialist Pharmacy Service in the UK. They've done a nice article on how medicines should be dosed in children who are obese. So it talks about the different types of drugs that are used, whether they're fat soluble or water soluble, and this makes a difference whether you should use the actual body weight or a dosing, an ideal body weight, a different dose. And if it is a case where a different dose, a different weight is used to calculate the dose, please specify that on in the notes or on the prescription, because we don't know otherwise if it's a different dose other than their actual weight. So do specify that as well. So the article talks about the UK WHO growth charts. So these should be used to determine if a child is obese. The height of the patient is required. It should be documented on the prescription, ideally, if not in the notes. And the adjusted body weight may be required. Is the child underweight? Have we got a 12-year-old who weighs 15 kg? Maybe we got to take a step back and think, oh, okay, hold on a minute, maybe we don't go with the age group based dosing for a child of 12 if they're only 15 kg. it would be more appropriate to use an age group that this weight is the average age for. So for a 4-year-old, dosing would be more appropriate if it was a 12-year-old weighing 15 kg. Just bear it in mind, it does happen, but the overweight patients and the obese patients probably a little bit more often, but something to bear in mind. So moving on to formulations and strengths. So in the world of pediatrics and medicines, we have to use a lot of liquids, and liquids present their own risks. Unfortunately, just because a liquid is licensed doesn't mean it's suitable for a child always. There are certain excipients we have to be really careful about in some liquids. For example, propylene glycol, alcohol, sugar content. It's more applicable to the very small babies and the small children, but trying to select a liquid that's most appropriate for a child is a challenge, particularly when we go down the route of unlicensed medicines. What strength to order? So the examples here, furosemide and comoxiclav. So furosemide, these are the different strengths available, and trying to select the most appropriate one. In community, you tend to be you feel like a little bit on your own, and trying to find the right people and the right people, the support networks to contact, find out this information. If you download the Clinibi app on your phone, under the medication monograph section, it has a lovely section on each different medication, and at the bottom of this are the preparations that they stock in the CHI hospitals in Dublin. So this would be a good reference point to maybe see what they stock, the concentration they stock. And in Letterkenny, we've adopted this formulary as our own local paediatric formulary as well. So that would be the strength that we should be stocking in Letterkenny as well. So that might be a reference source for you to use if you're wondering which strength is the most appropriate for that child. In terms of comoxiclav is an example where we need the strength most definitely specified on the prescription. So we need to know if it's the 400/57, the augmentin duo, or if it's the Germentin, the 125, 31.25. That's the TDS dosing, the other one's BD dosing. So we need this information on a prescription. Parents are an invaluable resource when it comes to medicines in children. Please don't be afraid to use parents. Empower them with the knowledge. Make them aware of the risks with different medications that their children are on. Tell them every time you get a prescription, this is what it should say on the bottle, this is the strength. Let them know that there are a whole range of different strengths that could be selected in there, and that they need to make sure every time they get a script or get a new dispensing of their medication for their child, that they're aware of the risks that possibly can occur, and that would hopefully negate any issues that arise. So the jury's still out. Milligrams or mil or milligram, what do you put on the box? What do you put on the label, rather? So first of all, I just want to say, I know it's common practice in community pharmacy to put the label on the box of a bottle. Ideally, it would be put on the bottle, not the box, and that would be my recommendation. What actually happens when they come in to hospital, they leave the box at home and they only have the bottle itself without any label on it. So please write in terms of the label, then make sure the milligrams and mils are on it. So the example here, take 4 mil, 60 milligram twice daily. That would be a nice label to have on it. But in terms of transfer of information between healthcare professionals, or prescribing use, only mass units, not mils. There are a few exceptions mentioned at Clinibi, lactulose and ferrous fumaric alpha. They should be prescribed in mils. So just be careful with, I know parents are a fantastic resource, but be careful, just sometimes their information can be misinterpreted, and the dose expressed as a volume of liquid may not appear too high, but it may become a lot more apparent whenever you calculate it out in milligrams per kg. So medication administration in children, don't be afraid to check in with parents. Ask how they are getting on. Sometimes you won't know about any problems. Maybe the kid is really just not taking the medication. Are you experiencing any problems? How much do you give in a spoon or syringe? What strength is the child taking? These are all really useful questions to ask. And ideally, the doses prescribed should be rounded to the nearest measurable dose. And we don't want a parent having to go home and measure 7.15 of a mil. It makes no sense. Round it to 7 mils. The general rule of thumb is rounding to the nearest 5% is fine. In terms of the volume of administration, then ensuring that parents have the correct syringe size, the most appropriate syringe size to measure the volume. So ideally it would be greater than 0.2 of a mil and less than or equal to 10 mils. I know this is unavoidable sometimes in the very small babies and if you need a very large volume of a liquid, but that's the recommendation. Just be aware as well, sometimes parents have a number of different liquids and they need a different syringe for each liquid because it requires a different amount of medication to be administered. So ensuring that they have an awareness and an understanding of how to use syringes and what the different markings mean on them. I'm not going to hold you much longer. I just have a few reference points for you that are fantastic resources and websites for parents and healthcare professionals. Medicines for Children is one of them. There's some really useful information here how to give medicines, some nice videos and step-by-step guides, and there's some QR posters as well here that could be printed off and put up in surgeries or pharmacies. They're really, really good information on this. It is a UK website, but it's a fantastic resource to have and to know about. So this is the CliniBee app I was referring to. So it is free to download. Please have a look at it. Some really useful information. So that's the paediatric formulary in the middle that you would double click into this. And then the medication monographs is the section where it would have all the information about the medicines. And there's some other information in general and medication safety and some very useful stuff about paediatric medicines as well. So the RCPCH is another nice resource to have, and they have some free paediatric prescribing principle and online learning, little CPD on that, and they also have other information on medicines in children that you can refer to as well. There's other more useful websites. I'm sure most of you know about them already. The other one at the bottom is the NPPG, the Neonatal and Paediatric Pharmacist Group. I'm a member of that group myself, and they have some nice information on that as well, along with the Specialist Pharmacy Service, the SPS. The BNFC, we would all hope, I hope you all know about that, and the Medicine Study at HPRA. So that's pretty much it. That's just a recap on all the different points. It's a bit of a whirlwind tour. I could talk about so many other things, but hopefully you picked up some practical information in terms of medications for children. And thanks for listening. My email is here if I don't get to answer all the questions, or you come up with any other questions later on. Thank you.
Joanne, that was great. Thanks so much for that. I've had a quick scan through the chat. I'm not sure if there are any questions there, but I had one question myself. Just, do you get much feedback from parents in terms of administering medications and associated errors in the school setting?
No, it's something, it's a huge area, and I don't think it's, from my point of view, I haven't gone into that area at all yet. I don't know exactly how schools, there's such a lack of pharmacy input in schools and medications in children, but I think it's something that could definitely be looked at in the future. I haven't received any feedback myself from parents, but it definitely has its challenges in terms of even fridge medicines and who's to give it, and teaching other people how to give it for their children. It does definitely have its own set of challenges.
Thanks for that, Joanne.
And I can see, sorry, Ida, I can see that Keith Durning,
okay,
the chief pharmacist in Letterkenny General, has been posting links to many of the resources that Joanne has mentioned. So if people want to go to the chat, you'll see links to many of the resources that were mentioned there.
Okay,